Good morning, everyone, and welcome. Today's presenter is Michelle Human. She's a qualified hematologist currently working at Ampath Laboratories. She has an interest in coagulation as well as veterinary pathology. She attended the University of Pretoria and obtained a BSc Human Physiology and Bachelor of Medicine and Surgery. She then completed her internship at a community service at the Bisa Hospital, and in 2021, she completed her postgraduate studies in hematology at Sefako Makgato Health Sciences. Thank you so much.
Thank you, Leanne. Okay, so today I'm going to speak on presenting an interesting case that occurred. It's a superwarfarin poisoning case. Okay, so the outline for the presentation, I'm going to quickly discuss the case. The laboratory findings of this case are summarized it shortly. This patient is actually currently still being monitored. This is 7 months post-exposure or post-presentation. I'm then going to just share with you the interesting history of warfarin and how it all started, the mechanism of warfarin, superwarfarins that we have in the markets today, and then the management. And if you're interested, you can look up my references. So the case presentation. This is a 45-year-old lady. After a few days of investigation, it came as to aware that she's actually working on a dairy farm. She's married and she has 2 children. Her youngest is 19 of age. So she presented in casualty with bleeding. Mostly it was epistaxis that can't be controlled. She also then, if you actually looked at her, you could actually clearly see subconjunctival hemorrhages. And then she was covered in subcutaneous features of hemorrhage, petechia, purpura, and ecchymosis. Of note, she had no history of trauma, and after other medical history information, she had no bleeding tendency. She had no history that she actually previously struggled with a bleeding problem. So we started with the FBC. Now, FBC is quite normal. So you can see our HP is within normal range, normal chronic, normocytic. So this is an acute stage. There's nothing chronically that you could see a vitamin deficiency or a microcytic anemia. You think it's a long-standing hemorrhage. The neutrophil count was also normal, so you're not thinking about infection. A platelet count was actually also normal, above 150. So there's no indicating of a low platelet count would cause the bleeding. Also on morphology, the platelets count were of normal size. So there was nothing abnormal from the full blood count. We did do the liver function test. As you can see, it's also fairly normal. The GGT is slightly range, or it's 77, with an ALT that's also slightly range. But with these parameters, you won't expect someone to present with such a bleeding problem with the liver function almost being normal. So what we did then is we did the coagulation profile. So we could see that the PT was markedly prolonged. It actually failed to clot. And we then did the PTT. We could see it's also prolonged. So what we then, after the prolonged PTT, we noted we did a correction factor. So what it means with when we do the correction is we actually take the PTT sample of the patient, half it, we mix it with another half of a normal plasma, and then we run the PTT again. This will only give us an indication, is there a factor deficiency? Because if you add factors that are working, it will normalize. So then we know it's a factor deficiency. If it does not normalize with the normal plasma, it shows that there's an inhibitor in this patient. And this was not the case in this patient's blood. And this is just an example for you guys, what we use just to monitor factors in our PT and PTT. So I want to show you that our intrinsic pathway is the PT, and the way that I remember it is plate tennis, it's your extrinsic factors. Plate table tennis, it's your intrinsic factors. So then we can actually see for our PTT, it was actually for factor 7, factor 10, and prothrombin is 2, and then a little bit of 9. So our PT, that's the test we use to monitor our patients on warfarin, and it's because most of these vitamin K dependent factors are being monitored in the PT. But as you can see in this patient, the PTT was also prolonged, and that's because there was all the vitamin K factors was used up in such an extent that it actually also affected our PTT cascade. And just for interesting sake, what is the causes of a prolonged or markedly prolonged PT and PTT that you have to think about? So first of all, it will be a vitamin K antagonist or deficiency or malabsorption, advanced liver disease where the liver is so deranged it can't produce all these clotting factors, and disseminated intravascular coagulation where there's consumption of all your factors because the patient is so septic or something occurred. Or then if the patient is known, it could be a common pathway deficiency or factor inhibitors. And then also if the patient's on any anticoagulants that could affect your clotting factors. And then also of note, if something is not fitting with the clinical picture, think about pre-analytical factors. Did they draw the blood incorrectly? Is there massive clot consuming all your factors, giving you a false indication of a prolonged PT and PTT? So this is just again a refresher of what could be the prolonged PT and PTT. So then after we saw that this patient had a prolonged PT and PTT, I added vitamin K dependent factor levels. And as you can see, the vitamin 2, it's very low, 7, 9, and 10. So these actually, gives us the idea that is this patient on warfarin? Did you take warfarin? I actually then did a factor 5 just to see that it's a non-vitamin K dependent factor, it's still normal. Factor 5 is also produced in the liver, so it's not the liver that's the problem. And then just a mnemonic to remember your vitamin K dependent factors. It's 2 plus 7 is 9, not 10, for in case somebody forgets. And then also an interesting thing is I just placed here all the vitamin K dependent factors half-life. So as you can see, factor 2 is 60 hours, factor 7 is short, 4 to 6 hours, with factor 9 being 24 hours, and 10 is also a bit longer. Very important to know that your antithrombin or antithrombophilias are screening, like the protein C and protein S. That's actually a mechanism within your blood to stop clots from forming. Is also vitamin K dependent, and they've got a shorter half-life. And this can cause problems if the patient takes warfarin and those factors depletes quicker. They can actually present with a thrombus, and then after that, bleeding. So it's going to be catastrophic. So I didn't trust these, after phoning the doctor, I told him, are you sure she's not on warfarin? He said, yes. So I did the warfarin levels, and yes, she's not on warfarin. So then I took the previous day sample, and I said, okay, I'm going to do toxicology. We did toxicology, and it came to, we got now evidence that this patient's got a superwarfarin on board, and actually the factor was protifocum. We picked it up as 3.4 milligram per liter. And I phoned the chemical pathologist, and I said, please just monitor this sample. It's very important. I want the results. And actually, I got phoned back by the chemical pathologist. He said he's never seen such a high level in his life. This is very high. At the end of my presentation, I'll show you a case study. The highest level reported was 3.7, and the patient died the next day. So this patient is actually still alive today, but presenting with this high level. And that the protifocum is one of the main ingredients in Ratex. There's also a few other rodenticides that's got this superwarfarin as main ingredient. So because this was a work in progress where the patient was bleeding, we wanted to investigate. So we would do just the basic coagulation screen, then your factors, but then I also asked for a platelet function test. Reason for this is platelet abnormalities will present with mucocutaneous bleeding. And I just want to show you guys, even if you do a platelet aggregometry to exclude a platelet abnormality, this patient had so much warfarin within it actually affected all the platelet aggregometry in a while that it's less than normal. This is not a platelet abnormality because you see all the platelets are trying to function, it's just not clotting. And this could be due to the fact that all the clotting factors are defective and also not helping the fibrin clot to form. So it will affect the clotting or the platelet function. And just a reminder of how to approach a bleeding patient. So the first step is just to determine if the bleeding is simply new or whether the patient has an history of abnormal bleeding. So if it is an inherited bleeding disorder, we will think about the platelet function, von Willebrand disease, hemophilia, or a rare factor deficiency. Other causes of no bleeding history in this patient will be a DIC, liver dysfunction, and what I try to put here is the medicational effect that happened in this patient. Acquired hemophilia and acquired von Willebrand disease is not really under risk because this was a healthy patient. And just here again, just to see everywhere you go, you have to think about the common and uncommon because in adults it will be traumatic or anatomical, and then next it will be medication, like in this patient. So the history of warfarin. Where did warfarin come from? How did it start? And it's quite interesting. So in 1920, there was an outbreak that occurred on a farm. It's usually in the northern America, Canada area, and they recognized that all the cattle started bleeding, that they call hemorrhagic septicemia. They noticed that if they dehorned the cattle, most of the cattle died. Small medical procedures, the cattle would bleed to death. There were no blood clotting. So this caused a lot of distress for the farmers. Then a Canadian veterinary pathologist noted that when the cattle ingested a moldy silage from sweet clover, that's the flower there that I showed, that they actually started bleeding. There was something wrong with it. So what he did is he took some of the sweet clover mold that he got in a hay ball, and he took stems that had mold on, and he took other stems that were fresh, and he fed those to rabbits. The rabbits that ate the mold ones died, they bled to death, and the others survived. So then they realized something in this mold or faulty hay caused the bleeding. So the identity of this anticoagulant substance in the spoiled sweet clover remained a mystery until 1940. Then this man came along, Carl Paul Harold Link. You can remember him as Carl Link. And he established that this anticoagulant was actually named 4-hydroxycoumarin, and he later named it decumaron. And that was after crystallization of this compound, decumarol, of coumarin in the plants. And he actually used this decumarol. It was the first widely commercialized drug that he patented in 1941 as an anticoagulist. He continued working on developing more potent coumarin-based anticoagulants for the use as rodent poisons, and that's resulted in warfarin in 1948. So where did the name come from, warfarin? So warfarin, it's actually an acronym, WARF, from Wisconsin Alumni Research Foundation. It's the university where Carl Link worked, and ending with RN, indicating the link to coumarin molecule. Warfarin was first registered as a rodenticide in 1948 in the USA. So you see there it was used as a rodenticide. And in 1951, Army inductee attempted suicide with multiple doses of warfarin. But he recovered fully after presenting at the Naval Hospital, where they treated him with vitamin K1. And studies began to use warfarin rather as a therapeutic agent. And it was actually found superior than decumarol, and in 1954, it was actually approved for medical use in humans. In 1955, the US president was actually on this after a heart attack. So it was used quite, and that's where warfarin started. So it was actually joked, and Link said that, he gave patients first cow poisoned, and after that, he gave them rat poison. That's quite interesting. So the mechanism of warfarin, how does warfarin work? So first of all, warfarin will inhibit your vitamin K epoxide reductase. So this will say that it won't produce reduced vitamin K. Reduced vitamin K is needed for the gamma carboxylation of your glutamine residues on your inactive clotting factors. So this will say we will not produce active clotting factors. And we will present, like in this case, with a decrease in the vitamin K dependent blood clotting factors. So what is superwarfarin? So this is a class of rodenticides that developed in the 1970s to overcome the resistance in warfarin in rats. So after they've given the rats warfarin, they started building up resistance, mostly the brown rats, but also common house mouse. So they started building or modifying the coumarin molecule and building more stronger warfarin molecules. The superwarfarins are long-acting, they're fat-soluble, and they've got a terminal half-life of at least 24.2 days. So they are 100 times more potent than warfarin. And the reason why they're doing this is they try to manufacture a toxin or rodenticide for rats. When they eat a little bit, it's going to be enough in their system to kill them. Not like warfarin, we have to take a little bit, then go back and eat your bite, take a little bit, go back. So they wanted something potent. A little bit will go far away. That's what they wanted to do. The problem is with these superwarfarins, very interesting, is you can get it via inhalation, transcutaneous, and oral route. And this has been documented. And as you know, it's been associated with accidental exposure, suicidal attempt, Munchausen syndrome. And if they do present with this, it's very difficult to diagnose. If they keep on saying, no, we did not take any medication, did not take any poison, it could actually mislead you to do a lot of tests before you get to your diagnosis. So awareness could be a problem among physicians if they're not thinking about this. This is just a presentation or pictures of all the superwarfarins that we know. So the patient here presented with protifocum, and here's a picture of it. So you can see the molecule has been added with phenyl rings. It will make it more, the rheumatic side change will make it more difficult to be excreted or excreted by the body, but also it will sit more stubbornly in your fat cells for long. And this, I just want to show you this coumarin molecule. This is actually the type of molecule that is present now in hay. And it's actually also the reason why you will smell that smell after you've cut grass is actually this molecule coumarin. But it's got a higher level in sweet clover that after it's been converted or fermented by fungi, that you actually get your decoumaryl molecule. And then it's been modified by chemists to form warfarin and then different other superwarfarin molecules. So what is protifocum? So the protifocum has an exceptionally long half-life on the body. It can range up to 9 months, some of the case studies over a year. So it's very important to remember that. This means that the patient will need prolonged treatment with vitamin K. This will be either in a human or in a pet. Due to its cumulative poison and its high lipophilicity, it sits in your fat cells, and extremely slow elimination and intrahepatic recirculation, it stays within long in the body. The other important thing to know is there's a lot of case studies and cases presenting also in South Africa that have actually used ratics with, you can say, cannabis, that they put it in and smoke it to get the better euphoria effect. But the problem is they then get the superwarfarin within the body, and it's really then difficult to treat these patients. Not only is it with the smoking, but also with other potent drugs that patients use, or they would actually use it in drinks at parties. I had one case in DGM, but it's actually a young girl that presented with bleeding, and afterwards we noticed that they actually spiked a drink with drugs that had superwarfarin in. Unfortunately, the patient passed away. I think she had a hemorrhage in the taxi ride on the way back. So it's very important to think about this if your PT is prolonged without any clear evidence to do toxicology screen, or even just a warfarin level, and then you will think further. And I put in this is from a journal where you can see protifocum has extended long half duration in humans, and it has been observed to persist from 16 to 270 days. So the clinical features of patients with superwarfarin, first of all, mucocutaneous bleeding, and hematuria is another common feature. Deaths are most commonly associated with intracranial hemorrhage, and also to be aware of the thrombosis that this patient could also present with while actually bleeding from everywhere. So this will be a very difficult patient to treat then. So with the management in this patient, what would we do? So first of all, if you know and it's known that they've ingested acutely, patient will actually not present with any evidence of bleeding, but it's important not to send this patient home. You will take a baseline PT on an R and you'll repeat it within 24 or 48 hours. Because mostly your PT and your PTT will start being deranged after 24 or 2 days, 48 hours. If you know the patient administered the diuretics or rodenticide, you can use activated charcoal, but it needs to be within 1 to 2 hours, else it will have no effect. Very important, admit to hospital. If you do feel uneasy about this patient, I do think it's better to admit them for psychiatric evaluation and to monitor anticoagulation. If there's significant bleeding, what to do? We can use a 4-factor prothrombin complex concentrate, as well as fresh frozen plasma, just to reverse or to supply all the clotting factors and to stop the bleeding. Then the next step will be to start intravenous oral or vitamin K as K1 as first-line therapy. It's important to note that you will start with intravenous vitamin K1. It will be at excess to 50 to 100 milligrams. Very important, as you'll see as I talk more, you will have to titrate the vitamin K according to the patient's clinical features and the PT. And then afterwards, a maintenance therapy of 100 milligrams per ounce vitamin K daily. Very important to remember high doses vitamin K. And then if the patient is bleeding, it will be red blood cells, and at end result, if the patient still, you can use recombinant factor 7. So vitamin K1. So it will take a while for the vitamin K dependent factors to start rising again. So just be aware of that. If the patient presents to you with bleeding, that's why you use fresh frozen plasma if needed, or PCC. If there's no clear consensus about the appropriate starting dose of vitamin K1, I think you will start with 50 to 100 and titrate it and monitor the patient's PT and PTT. Also, studies show that you can administer vitamin K1 orally, subcutaneously, intravenously, and intramuscularly. But there's no data comparing the best way of administering it. And I think it's actually quite clear intravenous is the best. You don't want to give it subcutaneous. You don't want to give it intramuscularly because the patient is actively bleeding. You're going to cause a hematoma. Also, orally, you're not sure how it's going to be absorbed. So give intravenously until the patient is stable. The reported dosing strategies range from 0.1 to 3 milligrams per kilogram per day, and you want to divide it into 3 and 4 doses. And this will be up to 500 to 800 milligrams a day, so it's quite high. The patient should at least receive twice daily doses and titrated in response to a clinical picture of bleeding as well as a PT. Maintenance dose of vitamin K can range anywhere from 15 to 600 milligrams per day, being most commonly the patient is prescribed home with 100 milligrams a day to be used. While there's no evidence based on safe concentration of the superwarfarin level, so this makes it also very difficult. But in the studies that I read, the bromidilone and brodifacoum levels less than 10 nanograms per milliliter. So remember nanograms per milliliter. We actually monitor the drug levels in milligrams per liter in AMPA. And that's very low. Only in that very low level can you actually say that the patient can stop the vitamin K and there will be a less risk of bleeding. Another strategy will be to discontinue your treatment and to monitor the activity of the clotting factors to see if they will rise. And then also, this will actually indicate to need, if they do not rise, to restart the therapy, or if there's a decline to restart. There's another important word that they use is hidden superwarfarin poisoning. And this is where the patient will not admit to ever taking anything, that the exposure is so bizarre that they don't know. And these patients are actually quite difficult to monitor because you don't know if they're getting exposed to it again. You don't know if they're eating again the toxin. So you need to monitor their superwarfarin levels to see if there's a downward trend and not a re-exposure. And in this case of our patient, she does not know where she got this rodenticide level in. It's like unclear for her. Her family didn't get sick. She's the only one that got sick. So for her, she's in denial. She did not take anything. So for her, it's very important then to monitor, make sure if she doesn't fit the clinical picture with the history, you need to monitor and make sure that you don't get exposed accidentally again. With this patient, I just want to show you that her brodyfocum levels, so she presented at the end of June last year, and it was very high. When we repeated it about a month and a half later, you can see it's still very high like 1 milligram per liter. And in October, you can see a month later, it's still high. Those levels are still toxic, and cases have been documented with people dying of those levels. So even though it shows that she's getting better, she's still in a lot of trouble if she stops. So in that patient, I just want to say this presentation makes it look like it was a very straightforward case. It's not. This patient actually, with her history, she was actually seen at a hospital. They treated her and they got her PT and PTT with the normal levels. Unfortunately, she was discharged home with 1 tablet of vitamin K. That's not sufficient. She represented again bleeding from everywhere, and they had to admit her again, started again with treatment IV vitamin K. The patient then got sent home again with a higher dose of vitamin K, but unfortunately defaulted, presented at another hospital, and the process started again. She also then got treatment, defaulted again. She presented at 4 different hospitals. In her the last 7 months, she presented also with a subarachnoid hemorrhage. She also developed hemorrhage in the spine, struggling to work. So this is a very difficult patient, and we're unsure actually because she's denying everything. Is this a psychiatric problem? But at the moment in January, when we monitored her, her INR was normal. Also, I've noticed that the general practitioner for her actually motivated for her to get a port, and for 6 months she received intravenous vitamin K. After 6 months, she got sepsis and the port was removed, but I think the danger zone is still out, and she's been counseled about vitamin K, so she's got enough vitamin K to if something occurs. So the take-home message is superwarfarin poisoning is a growing problem. It's just to be aware of it, especially with teenagers using it now in dagga and drugs. It should be suspected in all the patients with an unexplained bleeding with a prolonged thrombin time. And also, it's important to know that the follow-up of these patients, they were very long, months to year, and it's with a high dose of vitamin K, about 100 milligrams per day. And premature discontinuation of this vitamin K1 may reoccur the bleeding. And it's then very important to do your iron or your PT and as well as your toxin level just to monitor the patient and follow up. And these are my references.
Wow.
Thank you.
Thank you so much. Yeah.
Thank you. That's very interesting. Yeah.
Cool. Sorry, I've got a question now. So you said that the dose is 50 to 100 milligrams. So we normally give 10 of vitamin K per day. So can't you overshoot?
You can start.
In the sense that, you're so afraid. So if you give too much vitamin K, will it then cause clotting? Or
The thing is, I think in these patients where the patients are bleeding everywhere, you're going to start high and then titrate. And you can start high, then give a little bit lower just to get the factors working again. So unfortunately, I think there's going to be a risk of everything, but this would be in our life-saving. You'd rather aim higher.
And we also have to monitor the INR anyway. So
It's going to take time also for the INR to recover. So you can start with your fresh frozen plasma of PCC just to stop the bleeding, and then you can start with your higher dose of vitamin K and titrate.
Michelle, what I want to know was that I think thanks for lovely presentation. One of the first time clear that those patients are not very straightforward patients, and especially if they got really quite high levels that they're actually having bleeding problems. Because the blood is extremely very thin, they tend to present also probably underlying hypotensions, probably ischemic hepatitis. They might have features of heart failure with high lactate levels. So the clinical picture might be actually be very confusing to the physicians. And the problem with the clinicians that we treat what we know.
Mm.
We don't think beyond what you know. So the question that this is definitely have to be laboratory tests, diagnosis done actually clinician based. Okay, means so obviously hematologist should be willing to call the physician and ask for more information because sometimes the physician, you when your liver functions abnormal, you're more fixated that it's actually liver failure, while you're actually missing the superwarfarin. And I think that's what has been our problems.
Yeah, Michelle, I just want to know, with the drug being so lipophilic, is there a difference in the elimination rate in obese patients versus those with a normal BMI?
Well, I think just from common sense, the more fat you have, the longer it's going to be within you. They've done other studies where they took phenobarbital to actually help to excrete the drug more, but it's not been shown clinically effective. So I think it's going to be the amount of drug that sits in your fat. You'll have to wait until it's dissolved. So I think it's going to be longer. If you're thinner, probably shorter.
I think also from our side as well is we see a lot of patients with ODs. And we test for the common things, paracetamol, tricyclics, but we actually don't, and it should actually be standard practice to do INR and PTT studies on every patient and follow up as well, because you never know what these patients take. And it might just be using tricyclic antidepressant, but they might have other stuff on board as well. So actually we should check for it more.
I think because this is so readily available, something to think about. Because I know they usually say it's more prevalent in children that accidentally take it because it's on the ground, but actually adults, it's more common in females to take it.
So you give away, do your table tennis besides tennis.
I've actually got a very interesting patient in Mpumalanga now. We still don't know what the source of the warfarin is. It's been close to 9 months almost. I'm still keeping him on vitamin K, and he literally has a supply of it bank in his house because he's on constant vitamin K. The moment he drops it, the INR goes up.
So it's not the same problem.
So
It's probably if they did the toxicology.
exactly.
You know, I think the question, that's I say, you have to guide us because they obviously, our product have gone to the liver failure because abnormal liver function. And most of these patients, again, for whatever reason, their blood flow is normal. They still have an issue with their oxygen carrying capacity. So they need to have more hyperdynamic circulations. I've seen that patient with anaerobic even 6. They struggle. They feel lightheaded. These patients have been bleeding. So I think it's very important to make sure that I think we shouldn't be blindsided looking at how the patients are. I think once those markers are elevated, maybe we should actually routinely check for it. If you cannot explain.
If there's a markedly prolonged PTT,
Yeah.
I mean, you can just do the vitamin 2 dependent factors thing next. If that is low, then you go high. You do the
So that means you should be able to have that liberty to do that in the labs, because I think clinicians, we see the patient for 30, 40 minutes. The next time we see the patient the following day. Now we would not have what's only happened like based on previous cases. So I think it's a very good presentation.
I'm really glad you stressed about the higher dose of vitamin K, because if somebody tells me to give vitamin K, I'm also only giving 10 milligrams. I did not realize.
But you can give like 10 or 20 milligrams initially as a start dose, and then
we do that.
monitor the INR.
Yeah.
But again, you cannot give vitamin K in patients with on warfarin on metallic valve.
Yes.
Stay away from that. Only on non-metallic valves.
I do that continuously.
Yes.
That's why we don't give too much.
Yeah.
So I'm just wondering, the final diagnosis rests on the actual identification of the drugs. So what is the lab's turnaround time for that?
Well, first of all, the factors we can have in a few hours, so that will lead us. The warfarin levels, I mean, that sort of exclusion will be within a day. And I think the superwarfarin levels about 2 days.
Sure.
2
But
to
that's
3 days.
Yeah.
Because if you do press them, because you usually can take an old sample and say, "Your lab could do it now," and they will phone you immediately when they pick up something.
I think it's amazing. I've never really.
Yeah, I must say the physician that I phoned you was so surprised when I told him, "Listen, this is what's going on."
And you tend to see a lot of this in township actually. Farm workers, I've seen in Betal that somebody comes and then they bleed, you actually can't save them. Yeah, but sometimes you can find that sometimes they're having other, because you always screen for other viruses, and you find a virus that actually does nothing to do with it. And you can come with that. And that's where the issue, or sometimes because the CRP is slightly elevated, then you think it's a DIC. And so most of the time you really, it can be difficult to diagnose, honestly speaking. I think it's really hematologists next to you, and that should be kind of constant discussion. Thank you. For now, do you have any other topics to discuss? Lab results?